Good afternoon, everybody, and welcome to our suicide prevention webinar. Absolutely amazing to see so many people. I think we're at 102, so absolutely fantastic attendance. Thank you all so much for joining us, and thanks so much for our guest presenters that will be here with us today. So my name's Eloise Thompson. I'm project manager with the Community Mental Health Transformation Programme. My job today really is just to chair the webinar and just to sort of keep us on track, and but the most important bit will be what we're hearing from our guest speakers. If I could just remind everybody of some of our housekeeping rules. So the session will last about 50 minutes, so probably about 30 to 40 minutes of presentations, and then we'll have some time at the end for questions and answers. If everybody could please keep their cameras turned off and their mics turned off during the presentations, just so we're able to keep a little bit of focus on those presentations. The session is being recorded, so hopefully that's okay by everybody, but if anybody does have any queries or objections to that, if they could please contact Janine Pounder. Janine, I don't know if it's helpful for you just to put your contact details in the chat, so if anybody needs to contact you regarding that, they've got that information there. And then of course we'll be sharing all of the slides and information to everybody on the call afterwards. Next slide, thanks Janine. So as I've mentioned, we're here to talk about suicide prevention. So we've got a few presentations that we'll be hearing from today. So first of all, we've got David Stacey joining us. He'll be talking about the Lincolnshire suicide prevention strategy, then followed by Lucy Goodchild, who will be talking about Lincolnshire's suicide prevention campaign, running through the details of the campaign and the recently launched page on the How Are You Lincolnshire website. And then we'll be hearing from Jennifer Harper regarding the Amparo service, which provides practical and emotional support for people who've been affected by suicide. And then, as I mentioned, we'll just have the opportunity to have question and answers at the end. So I think without further ado, I can hand over to our first presenter, Dave. Hi, Dave. Do you want to just introduce yourself? And
Hi everyone, lovely to see so many of you on the call today. My name's Dave Stacey. I'm a registered public health practitioner, and I currently work as a programme manager in the public health team at Lincolnshire County Council. One of my areas of responsibility is around public mental health, and that includes and incorporates suicide prevention, hence myself being here today to talk to you about the strategy and some of the background data relating to suicide in Lincolnshire. Janine, I don't know whether you have my slides that you're able to share. Great, thank you. So just before I start, just a couple of things to say. Clearly with the topic that we're talking about today, some of you may find it upsetting or triggering, particularly if you have personal experience of suicide. So I just want to say up front, if you do need to take some time out of the webinar today, please do feel free to step away and to take some time to yourself if you do find it upsetting, any of the content. We have some colleagues on the call today who can help with that, including Amparo, but equally Samaritans are always available to provide you with support in terms of local, practical, emotional support if you or anyone that you know is affected by suicide. So I just thought it was really important to say that up front. The second thing before I start is to say that I am going to talk about some of the data, some of the statistics regarding suicide. And I think it's important to put that into the context that myself and partners who work on suicide prevention in Lincolnshire, we look at a lot of that data because it helps us to understand suicide better and where to focus our activity and our priorities in terms of suicide prevention activity. But it's really clear, and I and all of the partners I work with absolutely recognise that every death from suicide is a tragedy. And behind every single statistic, there's an individual and there's a family and there's friends and communities that are absolutely devastated by that loss. there's a famous saying that goes that statistics are people with the tears wiped away, and I think never so is that more important than when we talk about suicide statistics. So I just wanted to make it clear that it's important for context that we look at that data, but absolutely understand that there are people behind the numbers. Next slide, please, Janine. Thank you. Just on that point, we know from the evidence that every suicide affects up to 135 people, with a cost to the economy of about £1.46 million on average per suicide. So within that context and within Lincolnshire, on average, between 80 and 90 people die by suicide every year, and that therefore means that up to 11,000 people are potentially impacted by suicide in Lincolnshire, and that has an economic cost to it of £125 million to the county. Not that that's the most important thing, but it is also part and parcel of the impact of suicide as well. Next slide, please. So I'm going to talk a little bit about some of the statistics that we look at when we undertake an annual suicide audit for Lincolnshire. And I'm going to start with this before I talk about the strategy, because I think this provides some of the context and evidence that we look at as part of developing our strategy in Lincolnshire. So I'll look at the Office of National Statistics, some primary care mortality data, the coroner's data, and some of the police real-time suicide surveillance data that we receive regarding suspected suicides in Lincolnshire. There are a couple of other data sets that we tend to look at, but those are varying stages of development at the moment. So I'll focus on these particular four for the purposes of this presentation today. Next slide, please. So in terms of the Office for National Statistics data, in 2023, they reported in England and Wales just over 6,000 suicides, and that equates to a rate of 10.9 per 100,000. In Lincolnshire, that's 105 suicides in 2023, with a rate of 14 per 100,000. So significantly greater than the rate in England. Next slide, please. That from the data, what we know also is that suicides aren't evenly distributed geographically across the county. So we can see in this data suicides broken down by the suicide rate broken down by district council areas in the county. And immediately what is apparent from that graph is that you can see that Lincoln is very high with a rate of 20.1 per 100,000, significantly higher than the England rate of 10.7. But equally, South Holland has a high rate of 18.1. It's not evenly distributed, like I say, and West Lindsey has a significantly lower rate of Lincolnshire's of 7.3 compared to the rate of 14 across the county. So not evenly distributed. Next slide, please. We also know that it's not evenly distributed from the registered mortality data in terms of deprivation in the county. So what we see from this graph is that particularly in rural and urban areas, coastal areas, the numbers are small, so we can't draw a huge amount of conclusions from that. But certainly in rural areas, we see that the rate of suicide in the most deprived parts of the county are up to 3 times higher than those rates in the lower deprived parts of the county. And similarly, in urban areas, the rates are 2.7 times higher in the most deprived parts of our county than they are in the least deprived parts of our county. So it's not evenly distributed, and there's absolutely a slope of inequality when we talk about suicide in Lincolnshire that it's important for us to think about when we're taking action to try and prevent suicide in Lincolnshire. Next slide, please. So move on to talk a little bit about the coroner's data. So the coroner's data provides us with a huge amount of evidence in terms of everything that they collect about every suicide in Lincolnshire that they investigate, and it gives us some pointers in terms of some of the characteristics regarding the living arrangements and the marital status and a variety of different characteristics of the people that die by suicide at the time that they died. They're not necessarily reasons for why they died, but they give us that context that we can start to look at in terms of common characteristics and common issues that people face when they die by suicide, of which these are some. So living arrangements are just over 40% of people living alone when they die by suicide. 40% of people have had a previous suicide attempt, and that's a really important figure that we're doing some specific work on that I'll talk about in a little bit more detail later. That's up from the previous year where it was about a third. So there's a core cohort of people there who really need support, and there's an opportunity to support those people to try and prevent them from dying by suicide if they have an attempt. 37% of people weren't in contact with mental health services at the time of their death by suicide. I think that's another really important statistic. Not everybody who dies by suicide has a pre-existing mental health illness, and so but equally, nearly two thirds of people are in contact with mental health services. So there's certainly a lot more we can try and do there. 46% of people were self-employed or employed at the time of death. 24% of people were in skilled occupations, and that includes farming occupations within that as well, an important issue for us in Lincolnshire. And 48% of people were single at the time that they died. Next slide, please. What the coroner's data also tells us is some of the conditions and risk factors that were potentially contributory factors to that person's suicide. So we see from the data that mental ill health is a very common risk factor noted in the coroner's data, but equally known suicide tendencies, health concerns, previous suicide attempts, like I've said, but family relationship issues, alcohol and drug misuse are also really key risk factors in terms of from the data that we have on people who have died by suicide. So areas of focus for us in terms of our work. Next slide, please. We can also look at those risk factors by different age bands, because the risk factors do vary slightly across the life course. Commonly, mental ill health is a key risk factor and the top risk factor across the life course, but we see slight changes. So in younger age people who die by suicide, drug misuse is a risk factor. That tends to drop away a little bit as people go through into kind of working age bands, and then as we move towards 60 plus, we start to see things like alcohol start to creep into there in terms of risk factors. We also see family relationship issues in younger ages and into middle age and working age, and then as we move forwards and into 60 plus, we start to see bereavement coming up as well. And equally, health concerns don't appear in younger age groups, but they start to appear in working age and get higher in terms of a risk factor as we get older, which is understandable given people tend to start to develop longer term health conditions as they age, and those can start to become a cause for concern for them from a mental health point of view as well. Next slide, please. Some of these things I've covered already. I won't take too much time on this slide. A couple of points I will make is the most common method of suicide in Lincolnshire is hanging and strangulation, accounting for about 48% of cases in 2023. We do see some variation in terms of methods that people use though. So, for example, 34% of female suicides were by poisoning, compared to only 20% of males using that method. And we have also started to see an increase in drowning as a method in Lincolnshire's data. So typically we would expect to see an average of about 3 people die by suicide as a result of drowning each year. In 2023 there were 9 drownings. So that's something that we're focusing on, and we're also feeding up into regional conversations with NHS England about whether that's mirrored elsewhere, which there are some indications that it is starting to be a pattern. The only other point I'd make on this slide is about location. So the largest proportion, about 68% of suspected suicides in the police real-time suicide surveillance data, are in the person's home. There is also, however, a small but noticeable increase in suicides occurring in public spaces, parks and woodlands, but equally rivers, lakes and canals, which is expected given the increase we're seeing in drowning as a method. Next slide, please. So as I say, all of that data and context is important to understand, but equally important to recognise that every suicide is an individual tragedy. It has a devastating impact upon family, friends, the wider community. There isn't any single reason why people die by suicide, as we've seen in that data. It's often a very tragic response to difficult situations or feelings, including despair and lack of hope. And having suicidal thoughts or attempting suicide doesn't necessarily mean that someone has a mental illness, but a mental health condition is one of the recognised risk factors for suicide. So the Lincolnshire Suicide Prevention Strategy was co-produced with a range of partner organisations, whilst Public Health takes a lead role in producing the strategy and coordinating it. We can't deliver it on our own, and it's delivered in a large group of partners, and developing the strategy was no different. And equally crucially was the fact that the strategy was developed alongside people who have lived experience of suicide, which was a really important part of us in developing our strategy, to make sure we had the voice of lived experience running throughout it. The QR code on that slide will take you to a copy of the strategy, so you can look at it in more detail. The vision for our strategy in Lincolnshire is that Lincolnshire is a place where there are fewer deaths from suicide. People have hope, feel able to speak openly about suicide, and that everybody who needs support gets the support that they need at the time that they need it. Next slide, please. We also have some principles some guiding principles for our strategy in Lincolnshire. The first and foremost is that suicide is not inevitable, and it never should be considered as an inevitable thing. We have to do all we can to make sure that it isn't inevitable for many people. It's an all-age strategy, so similar to a lot of other integrated care system working and partnership working across the county, we tackle suicide prevention across the life course, from starting well to living well to aging well. The strategy and the actions flowing from it, as I say, it's not just about developing the strategy that has the voice of people with lived experience. We want everything that flows out of it and the actions we take to be developed through conversations and co-production with people with lived experience. It must be evidence-based. We must strive to achieve equity with the actions that we take. That evidence around inequality and the slope of inequality in deaths by suicide is really important when we think about what action do we take to make sure that we tackle those equity issues that people face in terms of accessing support. And organisations and the wider community must work collaboratively and in partnership, and that's kind of like what, you know, when I said about the strategy and delivering it, and we can't do it alone. Absolutely, we have a whole range of partners who work very closely with us to make this happen. Next slide, please. So in terms of the content of the strategy, there are eight formal commitments in the strategy that we and all of our partners have made to try and tackle suicide prevention in Lincolnshire. Underneath those 8 commitments are about 32 actions that, as a strategic steering group and as an evolving suicide prevention network, we're looking to address and take action against. So, as I say, embedding the voice of people with lived experiences is up front and centre and number 1 commitment. Reducing the stigma of suicide, reviewing recognised characteristics and risk factors, some of which I've been through with the earlier data that we talked about, in order for us to use an evidence-based approach about what do we know works in terms of addressing those issues. That would also help us reduce inequalities. Improving support for children and young people who have been impacted or bereaved by suicide. Recognising that life course approach, improving support for people who've attempted suicide, and we're doing some very specific work on that, which I'll talk about in a moment. And then ensuring that all key organisations provide suicide prevention and post-prevention support for staff and colleagues. So where we try to prevent suicide, we also know that in workplaces, colleagues and staff are affected by suicide as well. And so that post-prevention support is also really important from a workforce health and wellbeing point of view. Next slide, please. So just some of the actions. So the strategy was launched at the beginning of this year, but we've not rested on our laurels. We've really kind of kicked on to start to do some work and take some action against some of those commitments. And these are just some of the examples of that. So we have a communications and campaigns task and finish group that's evolved into developing the suicide prevention webpage, which I won't talk about because I'll hand over to Lucy, who can talk much more eloquently about all of the great work they've done on that since the start of the year. We've held our Lincolnshire Suicide Prevention Conference and network launch in September, and there's some information about that on the new website as well. We're also working with Lincolnshire Partnership Foundation Trust to develop 2 recovery college courses, co-produced with people with lived experience, targeting those who are at high risk or have attempted suicide, and another course for those who are affected others of people who have attempted suicide. So those are currently being developed. The first one of those courses should be ready at some point towards the end of this year. We're scoping out a suicide intervention service to support people in crisis or at risk of suicide or who've attempted suicide. Like I said, 40% of people who die by suicide have previously attempted suicide. If they don't present to crisis services as an immediate risk to themselves or others, they may struggle to get the necessary support that they need. So we realise that there's a gap there for certain individuals that we feel we could do a lot of support with to try and help them and prevent them from going on dying by suicide. We're developing a framework for embedding the voice of people with lived experience, and to that end we're in the process of looking at establishing a lived experience panel to support the work of the delivery of our strategy. And we've just launched the Suicide Prevention Strategy Grant Fund, offering out three £25,000 grants to the voluntary community, faith and social enterprise sector in Lincolnshire to support us with delivering the strategy commitments. The first stage of that is an expression of interest that's open until I think the end of this week, and then people who pass through that expression of interests will be invited to work up a full bid to access some grant fund to support their local communities with suicide prevention activity. And we've also commenced work with colleagues at the University of Lincoln to look at an evaluation framework for our suicide prevention strategy, both in terms of the individual component parts of it and the actions we take, but equally in terms of trying to get a sense of what the collective impact of the whole strategy will have been over time in supporting people in Lincolnshire. And then if I could have the next slide, please. And this is, you'll be pleased to hear, the last slide from me, which is a call to action. So within our strategy, we've included a call for action. The simple question is, do you know how to spot the signs? Ask the question, signpost someone feeling suicidal to support. And that myth-busting issue that actually talking about suicide doesn't increase the risk of suicide. It's really important, if you're worried about someone, that you ask them. And there's some free online training that can support you to have those sorts of conversations through Zero Suicide Alliance. It's a really short 20 minutes e-learning session, encouraging as many people to do that training as you can. In the County Council, we've made it mandatory for all our staff to undertake it, but they also have, as well as the generic suicide prevention training, specific versions available for taxi drivers, veterans, university students, and this year they've just released a specific version tackling neurodiversity and suicide prevention. So their courses are really, really helpful. If you haven't heard of them or haven't done them, I'd encourage you to do them. And then that's it from me. So I shall hand over to Lucy to talk about the work of the Communication Task and Finish group.
Fantastic. Thank you, David. Janine, do you have my slides? Perfect, thank you. So my name is Lucy Goodchild. I'm the Communication and Engagement Manager at Shine Lincolnshire. For the past year, I have been co-chairing alongside Public Health the Task and Finish group to launch the Suicide Prevention in Lincolnshire campaign. Next slide, please, Janine. Thank you. So the campaign has launched following the launch of the Suicide Prevention Strategy, which David just spoke about, and launched on Suicide Prevention Day this year on the 12th of September. And I'm here to tell you a little bit about the campaign, how it came about, and how you can use the campaign in your day-to-day work. Next slide, please. So the campaign, as part of an arrangement for the delivery of Wave 3 of the Community Suicide Prevention Programme, which is a funding pot of money ring-fenced for the VC FSE sector to provide localised projects to support those most at risk of suicide. £10,000 was ring-fenced to develop a county-wide awareness campaign in the form of a microsite. The aim was that there would be distinctive resources, and the campaign should open an honest and conversation about self-harm and suicide, promote access to support, and promote suicide prevention training. Next slide, please. So why was the campaign needed? I think all of the data that David has just showed us and the information strategy does show why the campaign was needed. The campaign is there to raise awareness about among communities throughout Lincolnshire regarding the warning signs associated with suicidal behaviour, and to ensure that people are confident to have those transparent conversations around suicide. As David mentioned earlier, it's dispelling that myth that those who may be at risk of suicide, if we ask the question, they are not more likely to take their lives. In fact, it is the most effective means of prevention. The main objective of the campaign is to equip individuals with the necessary knowledge and skills to facilitate this. Next slide, please. So the campaign is there to ensure that we have consistent messaging conveyed to the public, both to increase risk, but also to increase safety around suicide communications. It also will foster a sense of unity among both large and small organisations, and ensures that smaller organisations can communicate effectively about suicide prevention without the drain on their resources. The resources provided by the campaign also ensure that we can demonstrate our commitment to suicide prevention. Again, it means that organisations large and small can work to prevent suicide together without taking into consideration the resources they may have at their disposal. Next slide, please. Oh, there's one before that, please, Janine. Thank you. So the campaign also ensures that there is a singular approved message and resources around responsible communication regarding suicide, ensuring that we can all adhere to suicide safety standards. And while obviously the project did have an initial financial investment, the impact is significantly longer lasting and will impact future communities and generations in Lincolnshire surrounding suicide. Next slide, please. So we talked a little bit about the campaign, and you will see that the slides are the same branding as the slide used by David. That is because that is the campaign. So we'll talk a little bit about the identity of the campaign. Next slide, please. So it was really key that the campaign was recognisable as a single point of access and a brand almost that could be used by various organisations to ensure that we could provide accessible and compassionate support across Lincolnshire. So what you'll see is something that we worked with a designer on to create as a full branding suite as you would a new business, so that we could really ensure that there was that key consistent messaging across suicide prevention in Lincolnshire. So colleagues from Public Health, LPFT, Shine, Lincolnshire County Council, community organisations such as DWP and individuals with lived experience all came together to work with a designer over a series of task and finish groups to ensure that we embodied the values and the mission of the campaign, which are part of the wider strategy. And those values are accessibility, hope, support, reliability, connection and compassion. Next slide, please. As part of it being as recognisable as possible, the suicide prevention campaign needed its own logo. So we created a logo suite of primary, secondary, submark and logo marks, which means they can be used across a variety of media. And there is always a suitable version of the logo to be used across messaging to ensure that consistent branding and signposting to the campaign. The logo was developed with the Task and Finish group, and we really focused on that connection of weather and how, you may say that you feel a bit stormy, and we use those dark cloud analogies. And then also the warmth of the sun and the connection to bring hope and compassion. It was something that we felt that it was an analogy that everyone could recognise, and therefore the campaign would be recognisable and relatable to everyone. Next slide, please. As part of the campaign, a number of illustrations were created so that we could use them across print media and digital media, and each one works to maintain the themes of the branding of warmth, compassion, hope and accessibility, support, reliability and connection. You'll see from these two that it's really about reaching out to other individuals and how we can support people. They are all absolutely fantastic, so we do have slides with all of them on, but they are available to be used by organisations as part of their work around suicide prevention. Next slide, please. You can see that we really focused on that reaching out and that connection with other people, as well as starting those conversations with the speech bubbles and signposting Hey Lincolnshire, which is where the webpage is hosted. Next slide, please. Really wanted to focus on the impact that we can have on other people around us. So we know that each suicide impacts 135 people, whether that is a family member or a friend or indeed a stranger in a community, you may still be impacted. But equally, every small act, such as holding open a door, can make a massive difference to someone's life and can impact significantly more people than you would expect. Next slide, please. Things like paying it forward and ensuring that people aren't alone was the key messaging to show that compassion and that hope, and something that the Task and Finish group really focused on. Next slide, please. This is the key illustration that you'll see in most of the branding. It's one that really resonated with the Task and Finish group, with that feeling of feeling alone on a bench. You know, you have those really dark clouds, but actually someone coming along and holding an umbrella can make the complete difference in your world and go from thoughts of suicide to feeling like you can ask for help. It really portrays the values of the campaign while also maintaining the theme throughout the weather. Next slide, please. As part of the campaign, not only were illustrations created, but 10 social media templates were created to raise awareness of both suicide prevention in Lincolnshire, but also the webpage, so we can signpost to training, where to access support, and also hints and tips on starting those difficult conversations. Because we wanted suicide prevention to be something that all organisations, large and small, can commit to, these are all available to download for organisations to use ready-made. We want to ensure that people can show their commitment in as straightforward way as possible. Next slide, please. So I've talked a little bit about the branding of the microsite, and I'll talk about the microsite itself. Next slide, please. So the microsite, we refer to it as a microsite, it's actually a web page. I don't know the different technicalities, but it's hosted on Hey Lincolnshire and contains information to support those who are at risk of suicide, those dealing with thoughts of suicide, individuals who may be supporting someone who's struggling with suicidal thoughts, people who may have been bereaved by suicide. And again, that might not be something you've been bereaved by a suicide of someone close to you. It may be the ripple effect that each suicide has. It also includes information on what to do if you're experiencing suicidal thoughts, if you're worried about a child or young person, if you're a professional supporting a service user, and information on self-harm and support services, and information for those who are at risk of suicide. Next slide, please. Unfortunately, I have a 10-minute time slot, so I can't take you through the entire webpage, but you can see the drop-down categories that have been created to make it as easy as possible. When you have a chance, I would thoroughly recommend having a look at it, because each piece of work that has gone into these categories has been co-produced with individuals with lived experience, and all of the information on there is fantastic. And part of the reason that it's hosted on Hey Lincolnshire is that Hey Lincolnshire has a fantastic software called ReachDeck, which allows us to translate any page into different languages, different accessibilities. It can be audio read, you can have different colours and contrasts, and it means that the information really is accessible to everyone, because we know that suicide can impact anyone. Next slide, please. Next slide, please. As part of the campaign, we have a number of ready-to-go posters that can be put up in community areas and hubs to ensure that the campaign is recognised across the health and wellbeing sector, but also so you have something to give individuals you may be working with so that they can access the information easily. As we touched on, because the campaign and webpage is hosted on Hey Lincolnshire, it can be translated into any language. However, that's not particularly helpful if you don't know what to look for. So we worked with Boston Lithuanian Community Group to translate this poster into a Baltic and a Slavic language, that is Lithuanian and Polish, and that was done through statistics on the additional languages spoken in Lincolnshire, and they are the most common aside from English. And it does mean that someone who may be at risk of suicide who doesn't have English as a first language can still understand the poster and reach out for that support without necessarily being signposted. Next slide, please. You can see here the translated posters. We chose a Baltic and a Slavic purely because most Baltic languages and most Slavic languages have the same roots. So while they're not exactly the same, there are common similarities. So while they are specifically in Polish and Lithuanian, there is that ability to reach a wider amount of languages. And as we continue with the campaign, if they need to be translated based on data, that is something the Task and Finish group can do, and we can provide this in additional languages in the future. Next slide, please. Please say this is the last one. There's a QR code there so that you can scan to visit the webpage. It is full of fantastic information, and the Task and Finish group did an incredible job working on the campaign to support the strategy in Lincolnshire. Thank you.
Thanks very much, Lucy. If it's okay now, I'll hand over to Jennifer to talk about the Amparo service. Are you there, Jennifer? Hi, Jennifer.
Hello. You have my slides, I think. Hello, I'm Jen Harper from Amparo Service. I'm the Projects and Partnerships Lead for the North, and I also work as a liaison worker, suicide liaison worker, and have a small caseload myself. Next slide, please. So Amparo come as part of the Listening Ear. The Listening Ear is a Merseyside counselling charity established in 2015. Amparo has been running successfully across Cheshire and Merseyside over the past 8 years. We have now just run into the end of our 2nd year in Lincolnshire, and we'll be continuing support across in Lincolnshire as well. We now cover 30% of England, and you can see there all the ICB areas that we cover. And we are covering people affected by suicide to minimise risk of further suicide within our communities. Next slide, please. So the word amparo, why amparo? Well, it comes from the Spanish verb of ampara, which is the action of seeking help and protection. Amparo is the noun for protection, and in some instances means shelter. So the aim of Amparo is to provide help and protection for all bereaved or impacted by suicide. Next slide, please. What is postvention? So postvention is said to be prevention. Risks increase to individuals bereaved or affected by suicide, as we heard earlier. Public Health state those bereaved by suicide are at 3 times greater risk of dying by suicide. 9% of people affected by suicide will make an attempt within 5 years themselves. Suicidal thoughts increase and ideation may become intrusive for the individual. Next slide, please. So how does postvention help? Well, it's said to reduce risk, as we said, 3 times more likely to attempt to take your own life when affected by suicide. Reduces social isolation and prevents stigma. That's mainly in the older population where suicide was criminalised. It was decriminalised in 1961. However, the older population still see suicide as stigma, and by the stigma increases the isolation. And our aim is to reduce the isolation and talk about the suicide. We explain the process in detail at the client's own pace, and that process is dealing with the coronial services, with the police, etc. And it's exactly when the client is ready for that. Some clients want the support initially, straight after the loss, some, after the funeral. Reducing pressure on waiting lists. We are in contact with the client's GP, with client consent, of course, and should the client have issues with sleeping or increased anxiety, we can book appointments for the client, and it just prevents them having to call through to the GPs and converse with the receptionist about the issues that they're struggling with. We risk assess and safety plan with each contact with the client, whether that be by phone or face-to-face. Next slide, please. So in detail, we work with the coroner's courts, the police, statutory services and various third sector organisations to identify and support those at risk. Contact is placed within 24 hours of a referral. Support is tailored to the individual and offers a blended approach, including one-to-one practical and emotional support, liaising with police and coroners. It's important to remember this is an emotional support service and practical support service. Initially, the counselling offer isn't there, it's emotional support. We support at an inquest, so we will attend an inquest with a client should they request that. Referral and signposting support to local organisations. Everyone is an individual. Some people need more support than others. We do support to local organisations for peer support, such as SOBs. We co-create a support plan identifying the bereaved individual's unique needs and circumstances. That could be an increase of their mental health. Do we need more mental health support around the client? Do we need medication altering from the GP? This support can be provided one-to-one in family groups, groups of colleagues and peers, whichever is preferred by you and is most important in your situation. Most of our work is done one-to-one with clients, and within a family group, we may have 3 or 4 members of the same family and still work one-to-one because each family member brings up different emotions. And the meetings, our contact with client can be done in their own home, in the workplace, where we do group work, wherever the client is most comfortable. Next slide, please. So who is eligible for this service? Anyone who has recently or historically been impacted by a suicide. And as we can see here, that's just a sample there of next of kin, immediate family members, friends, colleagues, peers, finders, anyone working for Blue Light Services, anyone impacted by suicide loss. And we can also offer support to organisations that may have been impacted by a suicide. Next slide, please. And again there, anyone can refer into the Amparo service. It's open to anyone. Some clients prefer to self-refer, but if we can do a little bit of hand-holding and help them through the referral process so they don't have to verbalise or repeat their situation, that makes it easier for the clients to come through. Next slide, please. So how to refer? And identify the individuals affected by the suspected suicide. During the conversations that you might have with that client, offer the Amparo service as further practical and emotional support. Be mindful not to offer Amparo as a counselling service. And once consent is gained from that individual, complete the online referral form, and I'll show you QRS a little bit in the next slide or so, where we can come directly through to the web page. The Amparo advice line number there. It's important also to remember that this is a 9 till 5 Monday to Friday. It's not a crisis line. We're not at crisis support. Next slide, please. So what happens next? Well, the referral will go through to our office in Merseyside, and then will be allocated from there to a liaison worker within the area. A text message will come from the office to the client, potential client, just introducing the Amparo service and letting them know that one of our SLWs will be in touch. The SLW will attempt contact within 24 hours, and that again initially may be by a text, or it may be by a direct phone call if there's no mobile number available. Amparo will contact the beneficiary within 7 days, commence support and start to signpost to relevant agencies. As I said earlier, that support may not be required until after the service. It's a bespoke service. We go by what the client requires. And the SLW may contact the coroner's office for more information or to pass over information with client consent. And in a few cases, the coroner's officer hasn't had next of kin information, so we can pass that across to the coroner's office too. Next slide, please. And here we can see the QRS code, the telephone number, and as it says here, we'll help liaising with police and coroners, help with media inquiries, preparing for and attending the inquest, and finding other appropriate local support services. Amparo do offer CYP and adult counselling following our support. The that's an individual choice as well. Thank you. That's the end of my presentation. Thank you.
Thanks very much, Jennifer. And Jackie's just shared in the chat that she's used Ampuro's services both professionally and personally, and what a great job the service is doing. So thanks ever so much, Jackie, for sharing that as well. I wonder if Jennifer, if you wouldn't mind sharing your camera again, and Dave and Lucy, if we could please have our presenters back. Thank you all so much for all of the information that you've shared today. I'd like to open it up for any questions that people may have, or any feedback from any of our attendees today.
Could I just say, actually, that Amparo is a free service for everyone. Did mention that.
Thanks, Jennifer. Emma Louise, would you like to come in first?
Yeah, it's just a quick question. Just David mentioned that there's been an increase in drownings for suicide, and I was just wondering if we knew why. It's just quite specific, isn't it? So yeah.
We don't specifically know why. There are some common themes with drownings in terms of the other things that are in play at the point that someone may go into the water. We've had a couple. We have had some cases which have been mental health related, but equally alcohol and drug misuse related as well. Like I said in the presentation, there is some evidence emerging nationally that it's a pattern that's on the increase nationally as well. So we are part of a regional NHS England Suicide Prevention Forum that we have been discussing this issue with, just to try and get a bit of a better understanding as to the why that is. And that's where the coroner's data is so really valuable, because they give us that richer narrative about what was happening in that person's life at the point they died. So that gives us the best opportunity to understand some of that why, but there's no one single reason why that's happening.
Thanks. Greg?
Hi, Eloise. Hi, everyone. Yeah, actually, it's a question that kind of runs in parallel to the previous one. It's for you, Dave. Are you in contact with British Waterways or kind of any organisation because I'm just thinking, I work at the university. We've got a large body of water, i.e. the Brayford Pool, in front of our campus. I'm actually looking to build a pathway between ourselves and British Waterways to try and look at that risk. Have you got any contacts, Dave?
I can't recall whether they've been part of the suicide prevention steering group previously in Lincolnshire. I think they might have been, but I think through our emerging and establishing suicide prevention network, I think it'll be really important that we do reach out proactively to those sorts of organisations like the Canal and Rivers Trust as well, to make sure we've got those sort of partners represented in the network as well. So yeah, we'll definitely be picking that up in terms of making sure we've got that representation. Thank you.
And if you don't mind, sorry. I'm going to jump in there for one final point. Dave, if I can email you outside and just have the group and just maybe liaise about that contact, and if we can kind of identify that person, that would be fantastic.
Yeah, great. Thanks, Greg. Yeah.
Thank you both. Jenny?
Hi, yeah, Jenny from Citizens Advice in Lincolnshire. I wonder if and sorry if I've missed this, but I did look at the stats and it showed that the levels of suicide in Lincoln are significantly higher than the rest of the county and significantly higher than the national statistics. I'm sorry if I missed this and you said it, but what would the reason for that be, that they are significantly higher in Lincoln?
It's really difficult to get that level of understanding, because we can look at it from the point of view of our coroner's data and what evidence we have around those cases there. But then when we try and look at that from a comparative point of view compared to other areas similar to Lincoln, it's difficult to get hold of the data to that sort of degree of detail that we might be able to do that read across. So it's not, it isn't something that we fully understand in terms of the reasons why it's higher in Lincoln. I think all we continue to do is look at the suicide data in the audit to try and identify where there might be particular patterns in terms of methods or risk factors or characteristics for those individuals, to try and see if there's more preventative work we can do.
Yeah, I was going to say that if you knew that, then obviously you would align your preventative work to that, wouldn't you? Because I've noticed that in West Lindsey, it's much lower, and lower, I believe, than the national national.
Yeah, absolutely, and that's why one of our commitments is around equity, making sure that what we provide in terms of support for people around the county isn't a one size fits all, but that it's tailored to the specific needs of those areas as well.
Yeah, thank you. And my final question is, will we get a copy of all the slides, and how do we get those?
Yeah, all of these slides will be shared following the webinar.
Thank you.
Okay. Emma, did you want to come in with your question?
Yeah, my question's for you, Jennifer, and I'm really sorry if you've already answered this, but do Amparo support young people?
Hello. Yes, we do. But obviously the young people will come under an adult. If they're under 18, they must be, we must take them on our system under the guise of an adult.
Okay, thank you.
Thank you.
Thank you. Samina, did you want to come in?
Hi, good afternoon. I've got two questions, and I think I'm not sure who can answer them best. I work in prison, so I see a lot of self-harm in prison. I just wanted to know if there is any statistics or correlation, like people who do self-harm with like statistics that they commit suicide more, or because a lot of them in prison you feel like, or it's said that it's more for just to get attention or manipulate or what they want. So it's very difficult once they leave prison to know, like actually if they have actually committed. The one that commits suicide in prison, about if once they leave there. And the second question is like this prevention thing. Are we doing anything for people who are leaving prison? Is there anybody who's like looking after them? I don't work in Lincoln prison, but I work around here. It's not in Lincolnshire, but it's in East Lindsey.
For suicide, so the link between self-harm and suicide is a really complicated one. It's a bit similar to the point I make about the fact that not everyone that dies by suicide has a mental health condition, but it's a risk factor for suicide. Self-harm can be, for want of a better phrase, a sort of cry for help, but it can, there can also be an association between self-harm and suicide, but it's not a causal relationship. So it doesn't mean that someone who self-harms is either intending to commit suicide or that someone who self-harms will go on to die by suicide. So there's a really kind of complicated relationship between those two things. I think what we've identified in the strategy for Lincolnshire is we probably need to do some more work locally to understand that relationship in Lincolnshire, to see if there's something that we need to do specifically around self-harm. So our lead for suicide prevention in the Mental Health Trust, for example, has a lead for suicide prevention and self-harm. So there is something that we need to do on that, but it's not by any means a sort of nailed on causal relationship between those two things. In terms of people exiting prison, they would be able to access the kind of normal support that other parts of the community are able to access in terms of mental health support. So the sort of talking therapies that LPFT offer and those other kind of services that are out there, they would absolutely be eligible to access if they were coming out of prison.
Is that self-referral, you mean?
Sorry?
Is that self-referrals? Do the self-referral?
They could do, although equally I think they could be referred in by prison healthcare staff, I would assume, if that was appropriate. I don't work in the Partnership Trust though, so I wouldn't want to definitively say.
It's just that with my experience, it's mental health provision is quite poor in prisons, and they leave by like an appointment comes or something. That's what I was saying, is like, is it any better once they come out, or is there a way, is there possibility of someone coming out of prison? Because if they are homeless and they're going out, they would be in that position that they have nothing to look forward to or something. So if at that point of exit they were getting the support, or there was something that they could go to, might help them.
Yeah, thanks, Amina. I mean, I'll certainly take that query outside of the webinar, and I'll have a little look into it, and I can contact you outside if that's okay, just to see what some of those pathways are to support people. There is a number of questions in the chat which I'll come to in just a moment, but if I could just go to you, Deborah, first, if that's okay.
Yeah, I'm sort of following on from Samina. So I work on a contract with the Ministry of Justice for people on probation and people in prison with housing needs. So I wanted to just dispute one thing that David said. He said prison leavers are eligible for the same support as the average person. If they haven't got an address, then they're not. They might get referrals, but they won't get seen by anybody. So that was just one point. But I did put a question in the chat. So I work for Shelter, which is the homeless charity. On the data that you presented earlier, you said that so many percentage of people lived alone, but I didn't see, would homeless people be counted within that, or is there separate data for homeless people?
There isn't separate data for homelessness. So we pick up through the coroner's data where housing has been of concern to that individual on their records in some way, shape or form, but it doesn't detail whether they were homeless at the time of death. It may be that we could look at capturing that in future, working with the coroners to see if that is possible for them to do, but it doesn't currently appear in the data that we have access to.
So would they be classed as living alone then if they were on the streets when they died?
I wouldn't like to second guess how the coroner would code them. It would be dependent on the way that particular coroner was looking at the recording of that data. It may well be that they would record them as living alone.
And I noticed somebody else put a chat in the comments about housing having a significant impact. So yes, I just wanted to reiterate that certainly that's the case, and we are in the middle of a housing crisis. So yes, it is really, really difficult. I'll do that training that you advertised earlier, and hopefully can signpost some of our clients to support services that are accessible to people who are homeless or at risk of homelessness.
Yeah, thank you. I mean, there was an increase between the previous suicide audit and the most recent suicide audit in the amount of cases from the coroner's point of view where housing was a concern noted on that case file. I think it's about just under 10% of cases have a note of housing concerns on them now, which is an increase.
Yeah.
Nakomi?
On to what Debbie was saying quickly, just a reminder that although people are coming out of prison homeless, I'm the manager of Nomad Centre. We do have the holistic health team, which I don't want anybody to forget about. That LPFT do an amazing job with running, that are based at Nomads. If there's ever any referrals that need to come through specifying they need those referrals to Triple H to be done, then we're more than happy to do that, because they do have the physical health nurse, mental health nurse, social care and everything, and they do outreach, and they are there for the homeless, so they can support them with all of that.
Brilliant, that's great. Thanks ever so much, Nakomi. Just looks like that's all of the hands we've got up. I'm just going to quickly refer to the chat. Just a query, Jennifer, around Amparo. Is there a limitation on how long following the death that people can be referred into the service?
No, there isn't. Most of our cases across Lincolnshire are currently being referred in by the coroner's officers or the police. So that can be from day 1, day 2 onwards. We will support. And we have had blue light services have come through to Amparo 3-4 years down the line. If they attended a scene or something and it's stayed with them, it's impacted them. And also our clients come and go. So they may have come through the service, had some counselling, and then 6 months, a year down the line, it's all bubbled back up again. Something else has impacted them and it's all bubbled back up, and they can return to the service. We don't close the client and then they can't come back. We always close with the offer of, should you need to come back, please do. So historic or recent loss.
Brilliant. Thanks, Jennifer. There's a query around an increase in suicide on train lines. David, I don't know if that's something we're seeing in Lincolnshire.
We do have cases of that in Lincolnshire. It doesn't come through in our real-time suicide surveillance data from the police because it tends to be the British Transport Police that attend those suicides. So we are reliant on our relationship with the British Transport Police for information related to those. But I mean, there have been cases of that. I'm not sure I'd say there's necessarily an increase in them at the moment in terms of the pattern, but we do see them coming through. And I know, Jen, you work in Amparo quite closely with British Transport Police as well, don't you, in terms of providing support after? Yeah.
We do, and we also work alongside the armed forces, serving our veterans.
Thank you. Sorry, there's so many messages coming in. Just another one on any statistics around ethnic minority groups. Dave, is any of that the information broken down in that way?
The ONS do publish data broken down by ethnic groups. I think it's hampered in part by collection and recording and presentation of data when it comes to that. I mean, it does show, generally speaking, that suicide rates vary between ethnic groups. The highest rates tend to be between white and mixed ethnicity groups, but it's complicated in terms of other characteristics that sit alongside ethnicity when it comes to disparities in wider sort of health and care and social inequalities as well. So it's a complicated issue. There is some data out there, but it's difficult to draw really cast iron conclusions from it, certainly locally, because the numbers are small.
Thanks, Dave. I think that captures all of the questions in the chat. There's obviously quite a lot of comments and feedback about how useful and informative the session has been. I can't see any more questions from anybody in the room. So I'd just like to thank everybody. Thank you ever so much, everybody, for joining the webinar. Special thanks, David, Lucy and Jennifer for your time to present some really impactful and really informative information and all of the care and consideration that you guys have taken to relay all of that information to us. I think, as you say, Dave, all suicides are such tragedy with such devastating impact on so many people. So it's been really great to hear about all of the work that everybody's doing in Lincolnshire. Thank you, everybody. Thanks, everybody, for joining the session, and we'll look forward to seeing you next time. Take care, everybody.